Hi, I'm Doug Major. I'm an optometrist practicing in 4 offices in San Luis Obispo County. We have one dedicated specifically to vision therapy, which I practice with my lovely wife, Nancy Major, who's also a COVT. Always had an interest in special populations, particularly those incarcerated. Recently became a Z-Health trainer. Today's topic is the neurology of the Pepper stress test, or what can we learn from the emerging fields of functional neurology? Because those who knew Bob Pepper, the man why you have a trampoline in your office, the Pepper test was described as holding the scapula of one shoulder behind the patient and pushing back on the shoulder, the opposite shoulder, particularly on the shoulder that if you had a lazy eye or a suppressed eye, and asking the patient to fight against that pull. And the interesting thing is often when that patient did that torquing, the suppression would break. You would see the two strings on a Brock string, and sometimes you get 2 or 3 letters of better acuity with an amblyopic eye. I got interested in this and to answer a question that happened a number of years ago. Many of you here probably remember the time when after each COVD meeting, we would wait for the cassette player, cassettes, tapes of the talks. And one of my favorite was by Dr. Stephen Kuhl, who brought up the Pepper test in a relationship with this man over here, Roger Dowis. And I called Roger and had some fun doing a little bit of investigation just to make sure I got my story straight. But Roger and Ron Bateman were listening to Dr. Pepper at his seminar, and after 2 days, they got sort of unhappy that they didn't talk about binocular vision. So they raised their hand and said, Bob, when are you going to talk about binocular vision? And that's where Bob demonstrated the Pepper test and said, this is how I fix binocular vision, and moved on. Roger and Ron were livid and didn't know exactly how to handle that. But they had a patient that was difficult, and they tried it. And all of a sudden, the patient that had suppression could see the 2 strings for the Brock string and had made some progress. Well, at this time, this information was shared and Roger presented, and Steve Kuhl heard about it and went and said, Roger, I've always respected you, but how are you going to make me believe that shoulders are connected with, your visual acuity and binocularity? And so Roger gave this classic, and he said, hey, man, I'm just a clinician. I do what helps my patients. You're the one that calls yourself a visual scientist. You tell me why it works. And that question has always stuck with me, and hopefully today we can approach to answer that question. Unfortunately, it doesn't come through the regular channels of optometry. You're probably aware that functional neurologists seem to be grabbing the new material and moving forward. And particularly, I want to acknowledge the work of this gentleman, Eric Cobb, who's a functional neurologist and started Z-Health University. Also, the work of Dr. Cedric Noll, another functional neurologist who came up with this app, Focus Builder. You might want to explore it. It's very interesting about using eye movements therapeutically, and that's what we're talking about. And an early adapter is Deanne Fitzgerald with her Brain to Eye Academy. And really, if you have a right eye, you get an idea of this power of visual movement. I'm going to suggest that you all look those individuals up yourself. They all have great websites. They all have great education available. And particularly Deanne has some great webinars that are available for free and for a moderate cost. So I know there's many that are already saying, oh, these guys are intruding in our area. Just be aware we have a huge sandbox, and there's not very many of us playing in the sandbox. I think we should learn from those individuals and actually, hopefully, work together to meet the needs of our patients. So let's talk about simplified neurology. Again, when a nervous system really does three simple things: receives input, interprets, processes it, and creates an output, mostly motor. And the brain needs two things to stay alive: that fuel of oxygen and glucose, and it needs activation. It needs activation. You put two fingers together, or a primate, and almost immediately the brain starts treating them as one. And understanding activation, as far as a basic feeding pattern inside the brain, two things that are together often activate each other. In other words, you upregulate one area of the brain, and it also affects those neighbors around it, as Amy Thomas has demonstrated earlier. So let's get right to it. Brain stacking. It's just so fascinating, this location. So vergence and accommodation is in the midbrain with flexor tone. Pons has the abducens, the extensor tone. Cerebellum also extensor tone. And the medulla has, again, another area of flexor tone. So it's flexor, extensor, flexor. So just as Dr. Pepper upregulated the motor system to change the visual outputs, binocular vision and acuity, Cobb and others upregulate the vision system to change the motor outputs. So they're reverse engineering using visual skills to upregulate and do better with movement and motor. So what are the immediate applications? Well, let's think about flexor tone. So if you need to increase somebody's convergence, if you do an isometric flexion as you're doing convergence, you'll notice that will help drive convergence and accommodation if those centers are upregulated correctly. And the opposite, if you need to have better divergence, extensor, and you can actually stack this with your full arm to create a upregulation of divergence for those who have an ESO deviation. So eyes up helps extension, and it makes sense, right? We're looking up, we want to extend. Down facilitates flexion. Right rotation, like Pepper test, right extension, left flexion, and the opposite. These all can be stacked by using your motor system and your body, as well as the eyes driving the motor or the motor driving the eyes. So let's talk about neurology. Job one of the brain, of course, is survival. Is the body oriented more for survival or performance? It's more for survival. That fight, freeze, flight. Those who have a hard time understanding flexion, think of fetal position. Protection, down, in. That's the fear flexion, I would say. Number two of survival is the process can be summed up with pattern recognition. In other words, prediction. The more we understand the maps and patterns, the better we can predict the outcome. Accurate predictions reduces the threat, risk, pain, fall, all those things. So what happens when the brain can't predict accurately? Pain, fatigue, weakness, migraines. And the ocular motor nerves insertions for fight or flight or rest or digest are interestingly placed in the system. I always wondered, why do we have to have three types of ocular motor control? Why do we have three cranial nerves, for example? Ocular motor, the flexors, trochlear, also maximum flexor, I would say, and the abducens, the extender. But you think about that for a second, and when you you're in fear, you're going to go ahead and maximum flex. And remember, superior oblique down and in. When you want to feed and breed, you're going to go maximum extension. And in my mind, that helps me understand why these two these two cranial nerves are separate. Number two job of neurology is to move. And of course, that originates from the frontal cortex, cerebellum, and the pontine reticular formation. We're going to spend a lot of time on the cerebellum. And just again, this idea of neurointegrators, horizontal movements, the medulla, vertical movements, the midbrain. In other words, there's this separation of side to side and up and down. Sensory mapping, you need that correct body mapping to have a good sensory map. And that integration of the three main systems that we talk about, vision, vestibular, and cranial, and that needs to be integrated into the brain. So body maps come from input from joints and muscles. Visual maps come from inputs of extraocular muscles and the retina. The retina is the only part of the brain that moves. And so I would suggest that let's look at the eye as a coupled joint that we need to move around to explore and enhance to be mapped. When there is a mismatchment, reduces the predictability, increases the threat, and we all know these: vertigo, motion sickness, tension, scoliosis, weakness, anxiety. Now, this is the unique thing about Dr. Cobb. Inaccurate brain sensory and motor mapping can be accessed immediately by changing inflection and extension, their range and accuracy, the threat versus the predictive value of high performance. So if you do a eye movement that is uncomfortable or doesn't have a good map, it can actually threaten, and you'll see a change in how well the extension and inflection system works. And in thus doing, you can add activities that maximize the success and understand where the weak parts and weaknesses are in mapping body and brain. We're going to concentrate today on the cerebellum and why. This is where the maps, of course, are learned and stored. But there was a very eye-opening, no pun intended, experience that happened at the Academy meeting a few years ago when some researchers talked about what happened. Again, cerebellar accuracy, balance, coordination. And the researchers were Dr. Laura Alvarez, excuse me. And she works closely with Mitch Scheiman with this the neural basis of CI. And she did a number of tests, and then she really discovered, and this was just like a aha, that the place that the action occurs is the oculomotor vermis, so that's a cerebellum. So here's some of the information that she came from, that the oculomotor vermis changes with vision therapy. In other words, we have hard neurological proof now that the oculomotor system in the vermis is the place where the majority of the change occurs, at least as far as magnitude, when we do our convergence treatments. Another interesting phenomenon is when the cerebellum is injured, it can cause an acquired esotropia. And you think about that, again, the cerebellum is the extendor, so you break that down and you have flexion. I have so many people that are older that all of a sudden they are that little bit of ESO and seeing double. And it makes sense now in my mind because they have a cerebellum weakness. And those of us who have the right eye, just look how much it does in the assessment of cerebellar. You know, it's almost every time you have somebody with a brain injury, this cerebellum is red here, because all hypermetric eye movements is a sign of dysregulation. So when we overshoot all the time, that would be a sign of a right cerebellar issue. Dr. Hurst also gave an excellent paper here at KISS a few years ago, And she made this comment: learning in the cerebellum induces plasticity in other sites. Isn't that what we want? Recent study that reading errors in patients with cerebellar vermis lesions. So acquired dyslexia due to cerebellar impairment is maybe due to oculomotor alterations. So some great loops and connections for what we do and what we need to do. The cool thing about the cerebellum, it's so easy to test. You have just basic balance, gait, finger to nose. Every single joint you can make into a cerebellar test. And the big one, of course, is the Romberg's balance test. And again, we screen balance for, at least I was taught to screen balance for everybody, but I never really understood why and how to apply that. So let's talk about the contribution to eye movement. The cerebellum is intimately involved with real-time, immediate modulation of gaze shifting and gaze stabilization, as well as those long-term calibration. This is what we do, people. And so the areas of interest are the FOR, vestigial oculomotor region, the flocculus and the parathloculus, the nodulus and the uvula. Just so you know the interest in this, I looked up Neuroscience 2019. There was over 440 papers on when I used the search for cerebellar and ocular motor. This is the cutting edge of what we should be understanding and doing. So let's talk about these different regions and how they're different. The FOR, mostly initial acceleration and deceleration. The flocculus, eccentric gaze maintenance, and just the maintenance of pursuits, more of the angular VOR, and the nodulus, more of the translational linear VOR. And the cool thing is it's directionality specific. So we can tailor our treatment and our eye movement to meet the needs of the patient if they have more of a right eye problem versus a left eye problem. And so, for example, if someone has more of a right eye vertical pursuit problem, remember, or a right cerebellar problem, pursuits to that person's right is what we want to do. Now, oftentimes we just go back and forth, but ideally you would just go to the right, shut, to the right, shut. Well, let's investigate that a little further. Then, as Samantha talked about, there's an area for torsional pursuit cells. So again, using different locations can activate those people with torsional eye problems. Let's talk about, the first one is just basic gaze fixation. And that's that ability to stop and put your eyes where they need to go. And Dr. Cobb talks about, again, mapping the full range. You get an idea of how all these areas are so important. But looking up and holding 30 seconds, holding. Remember, our eyes only want to go 20 degrees. So when you go here, you're actually inhibiting the neck and, again, activating that floccular area. And then the other more associated with pursuit areas. And again, this idea of laterality for acceleration for the left, acceleration, and the deceleration. Think of your eye as a joint then again. So if you want to help to go in this area, if you start here, that's going to give you a little push to go up and back. If you want to make it harder, instead of starting right at the center, be a little bit off. Now it's pulling you back, and then go ahead and work on that one area. Obviously, this is more beyond what we can do in just a short period of time. I want you to get a pretty good feel about how exciting, using advanced techniques, as Deanne Fitzgerald would say, is for us as eye doctors. You'll notice that most of these are also accelerate in the down direction. So again, we have this tendency for, again, inhibition and looking down is the cerebellar contributions. So to simplify, for fixations and smooth pursuits, the flocculus and paraflocculus keep the eyes moving in the opposite direction of the ipsilateral, horizontal, and anterior canals of the VORs. And the POR speeds up the eye movements going in the opposite side and slows down the eye movements coming towards it. And going quickly, but if you would like it, get a screenshot of this. This pretty much puts in context all of what we've talked about here. We didn't talk much about the nodulus and the uvula. Again, that's more of an otolith information, so that's more the up and down direction. Very much like Dr. Pepper did such a wonderful job, stimulating this with all of the trampoline activities that he asked or prescribed. So let's go back to Pepper test. Shoulders and eyes. Is there the neurology? Well, look at this study. There's a salient cue and direct neurology in the shoulder muscles and the neck muscles, and even an increase in dopamine, which those on Syntonics love to think about too. For oculomotor reflexes, there's the tonic neck reflex. So again, controlled to the their other medullary tracts. The EMG activates was preferentially evoked by muscles ipsilateral to the direction of the rotation. So again, neck rotation and upper lens reflex in a man. Again, these are direct pathways that apply to the Pepper test. And again, when you look at all this research, it all goes through here, the cerebellum. Of course, I'm not forgetting the superior colliculus that is so closely associated with the mapping of saccades. We didn't really get to that. You can get an idea. This is become more and more complicated. By just stimulating electrically, you can make a normal monkey human strabismic in either direction, depending on where you put the application. So again, superior colliculus is also really important. So here's a couple other on-point research. Muscle fatigue for dynamic acuity changes. So again, the connection with the neck to ability to see with acuity, and then posture stability with assessment of balance to children with strabismus. And so just know, again, Dr. Pepper's clinical observations and practices have strong evidence and support, and would hope that you would investigate some of the research that's out there and the applications, these novel applications that those other members who are playing in our sandbox are doing. And maybe find somebody locally that, just like we talk about having somebody that does the craniosacral, maybe you should have somebody that is a movement therapist as part of your referral team. Thank you.